Assalamu alaikum. Bismillahir Rahmanir Rahim. Today, I will talk about multi-drug resistant tuberculosis and extensively drug-resistant tuberculosis. First of all, I would like to thank Pakistan Society of Internal Medicine for asking me to talk about this topic. Multi-drug resistant tuberculosis. Tuberculosis is an infectious disease which is communicable as well and spreads through air droplets during coughing, sneezing, laughing and singing or whistling. It is caused by genetically related mycobacterium called Mycobacterium tuberculosis complex. I will not go into the details of drug-sensitive tuberculosis because of shortage of time. I will first of all go into different definitions of tuberculosis. Resistant tuberculosis. Monodrug resistant tuberculosis is called when there is resistance to one of the first-line anti-tuberculosis drugs. Then there is a polydrug resistant tuberculosis in which resistance to more than one first-line anti-tuberculosis drugs is found, excluding rifampicin and isoniazid. Now, rifampicin resistance is when the patient is resistant to rifampicin, and important point to note is that if we find rifampicin resistance, we treat the patients as multi-drug resistant tuberculosis. And multi-drug resistant tuberculosis is defined when there is resistance to rifampicin and isoniazid. These are two first-line drugs. Then there are other terms. One is pre-XDR, pre-extensively drug-resistant tuberculosis, in which there is multi-drug resistance plus resistance to any of the fluoroquinolones, levofloxacin or moxifloxacin, or second-line injectable drugs which include amikacin. Then there is another term which is extensively drug-resistant tuberculosis, in which there is MDR, multi-drug resistant tuberculosis, and resistance to fluoroquinolones and second-line injectable drugs which include amikacin. And there is a newer definition of multi-drug resistant tuberculosis, extensively drug-resistant tuberculosis, which includes resistance to bedaquiline and linezolid. Tuberculosis is still the 13th leading cause of death, and it is the second leading infectious killer in the world after COVID-19. And in 2020, about 1.5 million patients died of tuberculosis, and about out of 10 million people, 56% were males, 33% were females, and 11% were children. And Pakistan is out of two-third high burden countries. Pakistan is fifth among the two-third high burden countries in as far as drug-sensitive tuberculosis is concerned, and even in drug-resistant tuberculosis also. As estimated, there are about 500,000 new cases of multi-drug and extensively drug-resistant tuberculosis, and 1/4 of these patients have access to MDR treatment. And out of those who get treatment, 55% were successfully treated according to the WHO survey. This multi-drug resistant tuberculosis is mostly found in Russia and surrounding states, and Pakistan. In Pakistan, around 3 to 6% cases of MDR TB are found in the world. There are about 3.3 of the new and 18% of the previously treated treated tuberculosis cases were found to be MDR or rifampicin resistance in 2019, and fluoroquinolone resistance was found in about 20% cases of MDR TB cases. In Pakistan is also fifth among the high burden MDR TB cases, and about 25,000 cases were found in 2019. Now, when should we suspect MDR TB cases? If the patient is currently on treatment, if their disease keep on progressing, or their sputum culture remains positive after 3 months of treatment, or if the patient is not regularly using treatment, or the patient is using inappropriate regime, then we consider these cases as suspect multi-drug resistant tuberculosis in these cases. And if the patient does not have prior history of tuberculosis and they present to us with an exposure to, if they have exposure to an individual who is suffering from tuberculosis, a case of MDR-TB, if they have near relative of MDR-TB cases, or they are resident of a place where MDR-TB cases are found, we consider them, we suspect multi-drug resistant tuberculosis in these cases. As far as the drugs are concerned, isoniazid and rifampicin, these two drugs, resistance to these two drugs is considered as multi-drug resistant tuberculosis, and isoniazid inhibits cell wall synthesis of the mycobacteria, and rifampicin inhibits messenger RNA synthesis. Now there are two types of resistance. First is primary resistance, in which mycobacterium shows slow constant mutation resulting in mutant strains which are resistant to these drugs. And the other one is acquired resistance, which is very important to know. It develops as a spontaneous mutation in the genes, and this is due to suboptimal drug therapy, which is very important. If the patient is having multi-drug resistant tuberculosis, or and they are not adequately treated, or if the patient is drug sensitive tuberculosis and they are not adequately getting treatment, they can develop drug resistant tuberculosis. The organisms, mycobacteria, develop resistance because of mutation in different genes which inhibit entry of these antibiotics or action of these antibiotics into these bacteria. As far as symptoms are concerned, patients with MDR-TB, they have similar symptoms of drug-sensitive tuberculosis, but these patients keep on, their symptoms keep on progressing despite irregular or regular treatment of drug-sensitive tuberculosis. And at the time of diagnosis, usually the disease is very advanced. For diagnosing multi-drug resistant tuberculosis, first of all, we do acid-fast bacilli staining with and fluorescein microscopy. If we find mycobacteria, then we ask for gene expert test. Gene expert is an nucleic acid amplification test which checks DNA within an hour or two, and it detects Mycobacterium tuberculosis. And the second part is detection of rifampicin resistance. So this gene expert tells us about rifampicin resistance, and if we find rifampicin resistance, we consider these patients as multi-drug resistant tuberculosis and start treatment according to the guidelines. The other important test is line probe assay, which is similar to this gene expert, and it detects isoniazid resistance in addition to rifampicin resistance. Then we also ask for acid-fast bacilli culture sensitivity to check for drug sensitivity testing also. This is an X-ray chest of a patient of MDR-TB in which the disease is advanced. There are multiple cavities in both lungs. This is HRCT scan of a similar patient with advanced disease. Now I will go into the treatment part of MDR-TB. As far as treatment is concerned, multi-drug resistant tuberculosis is treated in programmatic management of drug-resistant tuberculosis according to the WHO guidelines by specified centers of National TB Control Program all over the Pakistan. There are around 31 centers where drugs are provided free of cost. Moxifloxacin. These regimes are used for 6 months and have been effective in more than 92% of cases of MDR-TB. The second and the third regime, short-term regime, is for 9 months, in which intensive phase is for 4 to 6 months, which include bedaquiline, linezolid, high-dose isoniazid also used, ethambutol, pyrazinamide, ethanamide, and clofazimine. And these 4 drugs are used for next 5 months after conversion of sputum to negative. Then if the patients are not included in the short-term regime, short treatment regime, then we use long-term regime. And for preparation of long-term regime, we add these drugs from group A. Then we choose drugs from group B. And if we require another drug, then we use drugs from group C also. These are different long-term regimes which are being used for treatment of multi-drug resistant tuberculosis. Intensive phase is for 6 months, and then after conversion of sputum to negative for 12 months. Total of 18 to 24 months of treatment is used. And in other regime, which is long-term 2 regime, in which there is moxifloxacin. This is for basically for pre-XDR tuberculosis, in which there is resistance to moxifloxacin or levofloxacin. And the third long-term regime is for XDR tuberculosis, in which there is resistance to moxifloxacin and amikacin, second-line injectables. In multi-drug resistant tuberculosis, the patient has resistance to MDR TB cases. In these cases, we start with drugs which can penetrate through CNS. For management of multi-drug resistant tuberculosis, it is very important to monitor the cases regularly by clinically assessment is done and audiometry is done if the patient is using amikacin, and then culture sensitivity is also done monthly. Then certain tests are advised, and all these management is done in PMDT sites of where management of tuberculosis is done by National TB Program. Surgery is indicated for multi-drug resistant tuberculosis after about 2 months of treatment. And important point to note is that it is not considered in bilateral extensive disease, but if the patient has localized disease and there is a cavity formation which is not improving, then surgery is considered. These are different 31 sites where treatment of multi-drug resistant tuberculosis is done in Pakistan, all over Pakistan. And drugs which are used for management of this multi-drug resistant tuberculosis, these drugs are not, number of these drugs are not available in the market. And the patients are being monitored and they are being given financial support over there. So I suggest if we find a case, we should refer the case to these centers for proper treatment, and their counseling is very important. Still, there is low detection of MDR TB cases. There is high loss to follow-up cases, high death rate due to delayed enrollment, poor contact screening, which is being managed by NTP. And globally, there is incidence is falling at a rate of 2% per year between 2015 to 20, but it is halfway to the NTB strategy is laid down by WHO. This app is available on Android and iPhones, which can be very helpful to find out the guidelines of WHO guidelines about management of tuberculosis. These are different references from which I made this presentation. I thank you all for patient listening.